Hello, this is Kim Jong-il. Today we are going to cover indications of TPA Part 2. I classify the TPA indications into 6 categories. We can use the leeway space through TPA. The primary canine, first molar, and second molar are bigger than the permanent canine, first premolar and second premolar. However, the permanent canine eventually becomes larger than the deciduous canine. Therefore, the space must be carefully evaluated after the mandibular permanent canine erupts. If there is crowding after eruption of the mandibular permanent canine, it is possible to obtain 2.5 millimeters of space through exchange of mandibular primary teeth D and E. In the maxilla, 1.5 millimeters of space is secured. In the maxilla, the first premolar erupts before the canine. So we can evaluate whether there is crowding in the anterior region after eruption of the maxillary first premolar. Let's look at this patient. We can observe slight crowding in the maxillary anterior area. We can obtain 1.5 millimeters of space where the primary second molar was in the maxilla. In this case, we normally use TPA to maintain space in the maxilla. We can also use a band and loop appliance to maintain space. However, the problem is that even though TPA is applied, it is possible for the maxillary first molar to move mesially as the maxillary second molar erupts. Next, we will look at my own case that I misdesigned. I used TPA to maintain the space of the primary second molar, but as the maxillary second molars erupted, the maxillary first molars moved mesially. I should have used lingual arch instead of TPA to maintain the space where the primary second molar was. Therefore, I recommend using the lingual arc instead of the TPA to maintain the space in the maxilla. This patient displays slight crowding at maxillary central and lateral incisors. The primary canines are still present. Maxillary, right primary teeth D and E have fallen out. Primary tooth D on the left has also fallen out. In this case, it is better to use a lingual arch instead of TPA and to solder a hook to the rear of the primary canine in order to maintain space. We can also maintain space by applying a U-shaped loop to the lingual arch. As we can see, since the space where the second premolar can erupt is not enough, we need to gain space by moving the first molar backwards. For performing strategic leveling, the first premolar must erupt first, but the left first premolar has not yet erupted. In this case, we can wait for the left first premolar to erupt, and then obtain space for the maxillary canine teeth through strategic leveling. Secondly, we can make the maxillary first molar which is mesially rotated parallel. Here we must adjust one side at a time. If we adjust the right side first so that the buccal side is parallel, and adjust the other side in 4 weeks, we can obtain parallel rotation of the mesially rotated maxillary first molar by using TPA. However, in cases such as this, I recommend strategic leveling over TPA. TPA is not necessary for the derotation of the maxillary first molar. We can activate TPA if it is needed to apply TPA to maintain space in the case of mesial rotation shown. This patient was referred to me from another hospital. The maxillary premolars were only extracted, but the mandibular premolar. I thought that the maxillary TPA might be used to pull the maxillary anterior teeth to the maximum because the anterior teeth were severely protruding. As previously mentioned, however, it is important to remember that the maxillary first molars may be able to move mesially even though TPA is applied. So we evaluate the anchorage. The amount of anchorage required is divided into maximum anchorage, moderate anchorage, minimum anchorage, and non-extraction cases. Recently, absolute anchorage is also occasionally used through the use of mini-screws. However, TPA is unnecessary for moderate and minimum anchorage because the posterior teeth must be slightly moved forward. We require TPA or mini-screws for only maximum anchorage. There are several etiologic factors for Class 3 malocclusion. The first is the etiologic factor, extrusion of the maxillary first molar. To treat Class 3 malocclusion, intrusion to the maxillary first molar tooth is necessary. There are many ways to intrusion. Let's look at the My paper. In Class 2 malocclusion, the mandibular first molar is over-erupted. In Class 3 malocclusion, the maxillary first molar is over-erupted at the end of the permanent dentition. The treatment strategy for Class 3 malocclusion is to prevent the maxillary first molars from over-eruption. It is also recommended to induce the eruption of the mandibular first molars, as we would do for Class 2. How would we do this? We may use TPA around the maxillary first molars. In the mandible, we may use resin overlay on the mandibular milk molar to induce eruption of the mandibular first molar. Setlin has commented on the intrusion of the maxillary first molar. In this case, the maxillary first molar is relatively less erupted because the tongue is in contact with the loop of the TPA. When TPA is used, the tongue is raised, so the first molar is relatively intruded. In cases of Class 3 malocclusion, should the loop of the TPA face forward or backwards? Many orthodontists face it backwards for anchorage reinforcement. However, for Class 3 malocclusion, the TPA should face forward. We design the TPA like this so that it is about 3 millimeters away from the palate and that its loop faces forward. And we train the patients to put their tongues here. What outcomes can we predict? Through the training, repeatedly placing tongue on the TPA, the maxillary first molar would be relatively intruded. This intrusion will result in over-eruption of the mandibular first molar. The UOP will become steep. Because the mandible first molar is extruded, it can prevent the mandible from forward growth. In other words, Class 3 malocclusion is alleviated. Let's look at this patient. If we wait after installing the TPA, it is less likely for the maxillary first molar to extrude as the maxillary second molar erupts. What happens later? If we look at the vertical height of the mandibular and maxillary first molars, we can see that the mandibular first molars are relatively more extruded. It means that the maxillary first molar is relatively intruded. Impacted maxillary incisors often developed much and have abnormal root shape. If we extract the impacted maxillary central incisor, the alveolar bone is lost, and it is difficult to aesthetically treat it when implanting later. Therefore, impacted maxillary central incisors must go for traction. As mentioned previously, the roots of impacted maxillary incisors are extremely developed and have abnormal shape, which results in strong resistance to movement. When performing traction on the impacted maxillary central incisors, we can prevent adjacent teeth from being tipped by pulling a thick wire with an open coil spring. However, if we need lots of force to perform traction, the impacted maxillary central incisors may descend and adjacent teeth may ascend because of the principle of action and reaction, resulting in open bite. To prevent this, it is recommended to reinforce anchorage through the use of lingual arch before performing traction. The same goes for the maxillary canine area. If the maxillary canine is impacted, it is better to reinforce the anchorage with TPA and perform traction on the impacted canine in the desired direction on the auxiliary arch wire, rather than using an open coil spring between the lateral incisor and the first premolar. If the impacted canine is located labially, we could perform traction by soldering the auxiliary arch wire on the buccal side of the banded TPA, or on the lingual and then bend it buccally. The important thing here is that there should be some distance between the impacted canine and the hook. In the cases of scissor bite, the maxillary second molar is over-erupted and erupted buccally. How should we approach this case? First, it is important to intrude the over-erupted maxillary molar and tip it towards the palate. What should we do to achieve this? Many use crossbite elastics when treating scissor bite, but this is not recommended. Instead, we can use TPA with hook, fixed appliances, or mini screws. If multiple teeth have scissor bite, mini screws are recommended. If there is only one scissor bite, however, it is not easy to control the amount of force applied by using a mini screw. In this case, if we use TPA, solder the auxiliary arch wire and then pull the tooth with a scissor bite. It is easier to move to the palate while intruding it. Here, we need a guide wire so the power chain does not press on the gums. The maxillary left second molar of this patient is scissor bite. This tooth was pulled by using a power chain on TPA with guide wire and was arranged inside the dental arch. This is a non-extraction case with scissor bite at the maxillary left second molar and the anterior space. The maxillary left second molar was pulled by using a power chain and TPA with guide wire. We can see tooth number 27 is located in the dental arch after treatment. The problem in using TPA is decalcification and caries. Palatal side of the maxillary left first molar had decalcified after prolonged use of the lingual arch. To prevent such problems, TPA is best used for a short term. But if long-term use is inevitable, it should be recementated every 6 months to 1 year. Normally, the TPW increases by about 2.6 millimeters from age 7 to 15. Therefore, it is recommended to enlarge around 1 millimeter before recementing TPA for patients under 15. Let's look at the indications for TPA again. 1. It can be used for space maintenance. However, I prefer the lingual arch over TPA, even for the maxilla. 2. We can use TPA to derotate the maxillary first molar. For only the derotation of the maxillary first molar, strategic leveling alone is sufficient. We only use TPA while simultaneously derotating the maxillary first molar and maintaining space or reinforcing anchorage. 3. We can use TPA to reinforce anchorage, but I rarely use it for these purposes. Instead, I prefer to use TPA for the next 3 purposes. 4. To intrude the maxillary first molar in the case of Class 3 malocclusion. 5. To perform traction on the impacted maxillary central incisor or canine. In this case, it is recommended to use the lingual arch together. 6. To treat scissor bite. Thank you for watching.